Hello, everyone. Welcome to the keynote panel discussion around leveraging employer-provider partnerships to curb rising healthcare costs and improve outcomes. I would now like to introduce the moderator for this keynote panel discussion, Michael Thompson, who's the President and Chief Executive Officer for the National Alliance of Healthcare Purchaser Coalitions. Michael, thank you for being here today. I'd now like to turn it over to you to get things started.
Great, and thank you, Haritha. I'm really thrilled to have this opportunity to lead a discussion about employer-provider partnership. It's an area that we have done a lot of focus, including collaborating with Dr. Parodi, and Andrea has been a key participant in these discussions as well. Just a little bit of background, the National Alliance of Healthcare Purchaser Coalitions is the umbrella group for employer coalitions across the country. There's about 45 coalitions across the country and collectively represent around 45 million Americans. So with that background, I'd like our panelists to introduce themselves. First, Dr. Stephen Parodi from the Permanente Group and the head of CAP. And Stephen, maybe you could explain your multiple roles here.
Well, thank you, Mike, for the invitation. It's a pleasure to be here today. So I am Steve Parodi. I'm an infectious disease physician, and actually my year has been taken up actually leading the COVID-19 effort for Kaiser Permanente, which is a large group employer as well as a healthcare provider. We take care of 12.5 million patients across the U.S. And then in my operational role, I'm an associate executive director practicing in Northern California with responsibility for the hospitals and the continuum of care, as well as complex needs patients. I also serve as an executive vice president for the Permanente Federation, which is representing 12,000 physicians. And then also the chair of the Council of Accountable Physician Practices. So we're a group of 30 different physician practices that have been very invested in value-based care since the start, before the ACA, carrying that torch, if you will, and have been really interested and relish the partnership we've had with you and the Alliance to begin the discussions between physicians, provider groups, and employers, and trying to align, what are we talking about here? What do we need out of this healthcare system? How do we make things better?
And our other panelist is Andrea Cockrell, who has many hats as well, working with the city of Plano.
Hey, Michael. I'm also excited to be on this panel. I serve as the Administrative Services Manager for the City of Plano. We have about 2,500 employees. And I'm also the president of the Texas Business Group on Health. So I'm familiar with provider relationships. I think it's an exciting thing. And I think it's, if it works for your organization, it can really help you curb your cost and keep your members healthy. So I'm just looking forward to participating today.
That's great. And so, just to get us started, I from each of your perspectives, Dr. Parodi, why do provider and provider groups want to build more close relationships with employer purchasers, if you will? And Andrea, from your standpoint, why would you want to build closer relationships as well? And start with Dr. Parodi.
Yeah, so I would say that, number one, the way healthcare is purchased in the United States, for the most part, is through employers. And employers are generally purchasing it through a health plan or through a broker, if you will, middle persons. And the fact of the matter is that we saw an opportunity with physicians who really are providing longitudinal care. I mean, we're in it for the long haul. When a patient joins our practice, we're forming a relationship, and it's a multi-year relationship. And in the case of primary care, multi-generational often in nature. And really, employers have the same kind of approach here. Most employers are in it for the long haul. Their employees join, and the hope is that they're going to be with them for the long haul. So when you think about it, the approach that we take is that we want to take care of people and maintain their health. So it's not just about sick care, it's about preventative care. It's about actually having the systems in place to coordinate the care. So coordination amongst a primary care practice and specialty practices, or even within a multi-specialty practice. That means you need to have the incentives lined up properly, financial incentives, as well as the provider-centric, person-centered incentives. And then you need measurement systems to be able to look at that. And employers, we've found, are largely blind to some of those processes. So the employers are seeing, either what a broker is presenting to them, or literally claims-based data, which gives you a minimal amount of the picture. So we thought that it was important that the two come together, because a lot of our incentives should theoretically be aligned. But right now, the healthcare system, that's as it is set up financially, and as well as it's set up just from what we're reporting to each other, gets in the way.
And Andrea, that sounds very familiar with some of your own motivations. I mean, I know that you've actually taken action to actually deal more directly with some providers in the city of Plano.
We sure have. I guess about 7 years ago, when looking at our own personal data, we found that we had very dismal engagement in primary care. And that was something we wanted to rectify. And so we were looking for a partner that could help us achieve that goal by building a relationship. And as Dr. Perotti said, we are wanting to do this for the long haul. We're not looking for a one-year relationship. We want these individuals to find somebody that can serve their needs for their entire life. So when we were looking around, we looked at local primary care physician groups, and we partnered with one that had several locations, and just through steerage, through a very low copay, partnered with them, and it's been very successful. And I'm proud to say that since 2010, we've only had one premium increase in that entire time. So I do think it has helped us keep our costs low. Our premiums are very affordable, and most importantly, they have a quality place they can go for a very affordable cost.
And as you've engaged with each other, and not necessarily directly between the two of you, but with some of the coalitions, and Andrea, through your coalition with some of the providers and independently, what have been some of the biggest surprises you have landed on in terms of how either purchasers or providers are thinking? And what are some of those concerns? And what are some of the barriers that you've seen in how to work together more effectively? Dr. Perotti?
It's been interesting. So there's been, I would say, eye-opening sort of experiences for me in terms of the variability and understanding of how we look at quality, how we're looking at service, and then how we're looking at affordability. So those three components. So when I think about quality, I think about all those quality dashboards that get thrown at me, which is, these are the measures that HEDIS says, or these are the measures that AHRQ says, or these are the measures that, CMS is sort of saying is important. Those may or may not completely line up with what an employer thinks is important. And so being able to sit down and actually speak the same language. And in some cases, some employers are not even aware of any of those measures, and are not even, they're almost not even the same playing field in terms of asking the question about what quality is, because it's what the broker told them quality is. And so, that has been sort of one level setting piece. The second level setting piece is when it comes to service, and Andrea was just alluding to that. There's sort of what we're looking at. We may be looking at net promoter scores, or we may be looking at member patient satisfaction scores. That's not necessarily what the employer is looking at. The employer is looking at, I got 3 complaints from my employees in the last couple of days because they couldn't get in to see somebody because the hours weren't the right hours. That's not on a member patient satisfaction score. And so being able to sort of tease that out has been really important from my perspective. And then there's sort of this affordability question, and thinking through, what a value-based payment model looks like. And we've found that there's varying levels of understanding amongst the employers, and actually varying levels of interest, quite frankly, in it. And so being able to have that dialogue to say that, actually a fee-for-service structure, which is largely what our healthcare system is based on, often disincentivizes primary care, integrated behavioral health care. And both of those, by the way, primary care and integrated behavioral health care, were things that rose to the top in each of the conversations we had throughout the markets in the US this past year and a half.
Those are two areas we speak a lot about at the National Alliance and through the coalitions. And Andrea, what were you surprised as you engaged with providers? And I'm going to go a little deeper in just a second on some of those topics. So,
sure. I mean, I would agree that we are not, as an employer, you are not well versed in what maybe a physician would consider to be a good outcome. But from my perspective, what we want to see for our employees is we want to see them have somebody that is truly caring for them. They're explaining things to them. They're building a relationship. They're making sure that they're closing their gaps in care. They're checking on all aspects of their health, including mental health, being transparent about the process. So I think, with primary care in particular, that relationship is very much a big deal. And I am really not concerned, even if it costs more, because I think you save money in the long run by managing that relationship. So I mean, that doesn't really concern me as much, and we're willing to pay for good care. But I think, what I'd like to see a little bit further is, and this is where our talking to each other comes into play, is what is important to us, what's important to them, and maybe come to agreement and share that data bidirectionally.
and Andrea, I'm going to come back to you so we don't keep doing a ping pong here a second, but the issue of behavioral health, I'll throw in obesity. A lot of times what we find, what we pay for is for physicians to take care of the issue at hand, right? But when you're talking about a longitudinal relationship, and Dr. Parodi talked about a longitudinal relationship, it's really looking at people more holistically, right? And working with them holistically, short-term and long-term. How does that play into your plans, and why is that important to you?
Did you say me first or Dr.? Am I going first on this one?
Yeah, go ahead. Yes.
I mean, I especially this past year, it was so apparent that behavioral health issues were a big deal. I just noticed that the number of people on antidepressants, spiked, and people are more comfortable actually saying that they are seeing someone for a mental health visit. And so it's good to have that primary care engaged and even know, oh, this individual might need something a little bit more, and potentially even having that person as a part of the team is wonderful. So everything's interconnected. So that would definitely be something I think any employer would be looking for when partnering with a provider. I think it's very important.
Yeah. And Dr. Parodi, just
if I'm in here.
Go ahead, build on that, please.
Yeah. So when I think about primary care, primary care at the base of it should be the front door for behavioral health. And ideally, it's not something that's disaggregated. Too much of mental health care right now is disaggregated into a vendor relationship when it comes to either the plan or even the provider group. And part of the reason for that is the incentives that exist around mental health care. Let me just put it out there. The fact of the matter is you need time to provide mental health care. You need to actually be able to have time and space to be able to speak to a patient, understand what's going on. If it's a medication related management issue, the expertise to be able to provide that or get the consultation that you need, or to get a specialized referral if that's what's needed. And the fact of the matter is that it has not been paid for and not been incented. You need to actually basically incent primary care providers to provide population-based level care. You mentioned obesity. I could mention hypertension, I could mention diabetes, but let's focus on mental health care. If I'm paid on the basis of taking care of an entire population, even all up into capitated payment, I then have the incentive from a longitudinal perspective to provide that level of care. And if I'm in an integrated system, what that means is if I have mental health providers that are within my group or at least directly contracted with my group, then I've got now a network to be able to work together so that it's not a one and done. It's actually the team-based approach to behavioral health, which we know leads to better outcomes. I'm sorry to wax
but
hard on this, but I feel very passionate about it. And the last thing I'll just sort of mention here is that this past year, as Andrea was referencing, there's been a spike in the amount of mental health care. And I believe there's actually been a tail to this when it comes to COVID-19. Even after the pandemic has waned, we're going to have a large population of traumatized people. And telehealth has been a big important part of extending our ability to provide more mental health care in the US during this pandemic. And we're going to need to be able to make sure that that remains integrated, remains a part of how we provide mental health at scale.
So I'm going to come back to that in a second, but I wanted to push a little bit further on some of this integration, right? So we at the National Alliance are increasingly focused on what we call total person health, looking at the interrelationship of multiple chronic diseases, behavioral health on physical health, or even social needs and all of that. It seems to me that it's almost impossible to optimize care if you're not thinking that holistically. And Dr. Perotti, has that been your experience? How do you provide care if you're not thinking with that broader lens? And again, I think part of that takes time, as you said, and frankly, maybe different payment models to support. What's your take on that?
So it totally resonates with what my basic practice is. So let me just get very granular for a second. So I have an HIV practice. I've been doing that for more than 20 years now. No way I could do HIV care without a social worker, without my nurse case manager, because inevitably when a patient comes in and they say, I'm not taking my meds, there's probably like 3 orders of different reasons for why they're not taking their meds. Is there a problem with the cost? Is there a problem with their insurance coverage? Is there a problem with adherence at home? Is there a problem with, actually other priorities horning in on their ability to address their actual medical care? Is there a mental health issue? All of those things have come up over the years in my clinical practice. So you have to have that holistic approach. Now, let me just give you broader perspective real quickly here that's come up in the course of the pandemic. So I'm going to give you the story of the red truck. Okay, so this is a patient who we ended up admitting into what is a new hospital at home program. A person had been coming in with infections of their leg because of swelling in their leg. And we went out to the person's home, and guess what we found? We found a broken CPAP machine, and the person's obstructive sleep apnea wasn't getting treated. We found a refrigerator full of salty food. And we found a person who was disaffected, and we weren't addressing their full, basically, goals of care. We said, you know, what's going to motivate you to get that CPAP machine on? What's going to motivate you to change your diet? And he had this fancy new red truck in his driveway. And he said, I want to be able to drive my red truck. And the entire hospitalization at his home, by the way, handled by a remote team, was focused on the red truck. And we got that person a new CPAP machine. He's eating a new diet. His infections gotten treated. But that just sort of gives you an example of, you know, how we need to get into people's homes. And we can do it now remotely. And you've got a care coordination team that's addressing all of those pieces. That's how you really get at this stuff.
And Andrea, it strikes me that the average employer isn't that engaged in how what they pay and how they pay leads to better care. And invariably, we'll probably end up with advanced primary care spending more on primary care. First of all, is that okay? Two, how aware are you in terms of how you're paying is influencing that care and what you could potentially do about it?
I totally agree with you that most employers are not aware of, you know, what they pay, period, and you know, where those buckets of money are going. So, and it is challenging to even, when you are engaged, to even see how that's having an impact. There's so many variables, but, you know, I agree with Dr. Perotti that when you are looking to partner with someone, you want to make sure that they have the care coordination resources, you know, the social worker, the mental health providers as part of their team. And we have that in place right now. And one thing that was really cool is we reached out to them during COVID and said, you know, can you guys assist us in doing some trainings via Zoom on, we had a whole series that was very popular over lunch on different mental and behavioral health topics. So if we did not have that kind of dialogue where we were talking directly, that's something that never would have occurred. So that was pretty neat, and just another reason why you would want to partner, you know, partner with providers and speak to them directly.
And Andrea, your results, I was, you know, you kind of said it in passing, and you said, well, our costs haven't gone up in a while. Do you tie it back to the fact that you are engaged more actively on primary care and investing in that area?
I think so, because we had a pretty, our trend kept going up and up. And so we, you know, had a strategy session, and that was one of the areas where we were really not doing very well. So we made an effort in that area. And again, we're in it for the long haul. We try to make it as easy and simple on people as possible. But the main point is just take, you know, go in once a year and take care of yourself. And now they've developed the habit of doing that, and they know they're engaged in their own health and wellness. So that I think is directly attributable for helping keep our costs flat, pretty much.
And Dr. Perotti, it's funny, as we've done our work on advanced primary care, it isn't hard to build a consensus on what good care looks like. What's the hardest thing is to help people understand how to pay for high value care and how to mitigate low value care. And a lot of times our incentives just aren't aligned into our typical fee for service medicine. And you mentioned telebehavioral or telehealth more, you know, there's a reason we don't do as much telehealth. People don't get paid as much to do telehealth, rather than have them sit in the office for an hour and wait for an appointment for a 15-minute handshake and out. So how do we get ourselves thinking more aligned with this very high impact, high value care, and a little less of this treadmill to get paid. Help me understand what the opportunity is here.
So a couple of things. So one piece here, which actually wasn't, and not necessarily naturally an interest of employers, right? Because employers are the ones purchasing insurance. So I always am cautious when I start talking about government programs. But I think actually right now there's an opportunity for employers and physician groups to partner around making some of the telehealth waivers that made so much of the care possible during this pandemic, make them permanent. Those are actually winding their way through Congress. They're winding their way through state houses. And we should actually be speaking as one voice on those. Because to your point, Mike, the issue around payment parity, particularly around both video visits and audio only visits, is an issue that's at the fore. And health plans actually generally follow suit. If the government payer plans will pay for parity, then they follow suit with employer purchased plans as well. So I think we have an opportunity here that's a watershed moment that wasn't available pre-pandemic. I would say the second thing, and this gets more to the broker level question, is that we both need to be singing on the same song page and saying that both of us see value in this. And value from the health plan perspective is that ultimately we're actually going to save money. They're going to save in claims if we go upstream and address these issues early on and head on. And then the last thing I'll just say is that there's also the education that I was talking about around value-based purchasing, to say that, whether, and it's moving beyond the ACO model and the bundled payment models, right? Which we're looking at, episodic levels of care and getting to the primary care focus and saying, no, there's actually an incentive to say, if you have a population of employees under your care and you're able to show better outcomes, whether it's blood pressure measurements or your hemoglobin A1Cs are better, or your number of, and we have these conversations with our employers, this is CAP groups all the time, really, when it comes to, are we seeing less ED visits? Are we seeing less hospitalizations year over year? Having those kinds of conversations, which are more meaningful than saying, we had this many claims and this is how much we paid out.
And what's funny is you'd say, first, if we invest the money better, if we align the incentives better, we save on total cost of care downstream. And sometimes it doesn't need to be years later. It can be in the same year. I mean, this is not rocket science as to how you better manage. We underinvest in primary care and we misalign how we invest in primary care, right? But the other part of it, to me, Dr. Perotti, is it's better care. It's better for the physician. It's better for the patient. This is not like telling people to do things that aren't in their instinct of providing better care. It's just allowing them to practice the way they were brought up in medical school. Is that true?
Well, yeah, absolutely. And you're getting at sort of this other piece, which is, this is what we're about. Okay, so one of the biggest frustrations, we all have been going through burnout, right, in some form or fashion in this past year. But it's not lost on people that people in medicine have been frustrated, and there has been a lot of concern that people are leaving the field or don't want to go into the field. And and I actually have heard this from employers too, that they're concerned, and they're concerned from the standpoint of, these patients do develop trusted relationships with providers, and that longitudinal relationship is valuable. And so if you have people leaving the field, that's a big problem. Or you have people not going into the field when it comes to behavioral mental health. And so, yes, that's absolutely right. You've got to align the incentives so that people can actually get back to the basics. I was kind of, commenting on the move towards more home care. I was referencing hospital at home, but it goes way beyond that. When it comes to chronic care at home, primary care at home. And I liken it to, getting back to the old black bag kind of method where, we would actually make house calls. It's kind of back to the future, except it's actually technologically enabled. And so all of those things occur if you have a more value-based approach to care.
And Andrea, employers spend a lot of money trying to help their employees lead a healthier life, improve their well-being. And yet, if providers are properly motivated and engaged, they can be more successful doing the same things that you've been trying to do, or you or other employers have tried to do on their own. What's your take on that?
I totally agree with you. I feel like there's an opportunity for us to maybe get rid of some of these things that we're spending money on, like wellness portals, biometric screenings, stuff like that. It doesn't seem to add any value to the care of your employees, but part of the relationship with the primary care group is you're going to do all of these things for us for a per member per month type fee, and we're just doing business a little bit differently. Like even the home, in my mind I was thinking it'd be great. We always talk about meeting people where they are. So, a lot of individuals would probably appreciate it if the physicians could maybe occasionally go on site at the employers and check up on those. But I think I don't know that, as an employer, we love the fee for service either. I think that there's opportunity to amend the model to make it better for everyone.
Yeah. Well, and we get the system that we built, right? We get the system that we incented, and the system we incented produces what we typically have, and what folks like you have done is kind of turn that on its head. One other thing I wanted to explore a little bit, we've talked a lot about value-based payment or design, but you also talked about removing barriers to care. Some of your people don't make that much money. And a lot of times in the era of, quote, consumerism, we said, well, patients should be able to make their own choices and they won't use unnecessary care if we just make them pay a lot more. Did that work?
Well, we've never engaged in that model at all. And I think actually what I'm seeing now is employers that have done that are getting away from it because it doesn't work. I think, we want people to go see their primary care physicians. We don't want to burden them with a $200 visit. And I certainly wouldn't want to pay that myself. So whatever we can do to support that, I think is good at that level of care. I think it makes a lot of sense.
It seems to me that your primary care physician is that trusted advisor by definition.
Agreed.
And if they're just acting appropriately, clinically appropriately, responsibly, yada, 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 your employee's in good hands if the primary care physician just advises them appropriately. And Stephen, I think you've probably seen some of the impacts of what we've done with some of the employers with some of our designs that have created some barriers to care, and frankly, hasn't always led to better care or better outcomes.
Yeah, I agree. And, one of the things that I think is almost a case in point here has been the vaccine effort. And I'm going to use it as an example where things can go right. Now, there've been a lot of difficulties with vaccine supply and whatnot, but what we're finding now that supply is not as much of an issue, is actually that employer and physician interface is going to be critical if we want to get to what we want to call herd immunity. So I really think of it as three different things: access, education, and trust. So when it comes to access, Andrea was mentioning this, extending the hours, making it on site, making it more accessible in terms of where you go to get it. So no longer the mass vaccination idea, but in your actual doctor's office. How about that? Something novel. And then popping them up in particular areas in the community. And by the way, it's not like the physician groups all know where those are, and employers do, city governments do, and that kind of partnership. So that's number one. Access, education, multi-channel education. Okay, so understanding, and we've engaged with employer groups. Is it text messaging? Is it emailing? Is it a flyer on the wall? Whatever. What is going to reach people? Who's going to reach the people? Who's the right messenger? And who looks like the people that need to be messaged? And that really goes to that trust factor. And so that can only occur with dialogue between employers and the physicians. That really can't be brokered by a middleman. And so us being able to work together to promote those trusted messengers, I think, has been key and will be key in the coming months. What I hope we have here is sort of lightning in a bottle, if you will, because this doesn't have to be just related to vaccines. All those basic primary care related issues, those are very much rooted in what we're describing here. If there's anything that we've learned, at least during the course of this pandemic, is that this isn't all going to be propped up by public health alone. This is going to require, us private entities getting together and making this happen.
I was listening to your comment on access, education, and trust, and I was like, boy, maybe those are the three key ingredients to value, right? We need to provide affordable access and convenient access to individuals, and I think we've heard that discussion here. And we clearly need to educate, but not depend on them being educated to get there, right? We need it's both, and employers do a fabulous job, I think, continuously reinforcing what's needed, and I think we need to continue to do that. And frankly, employers themselves need to be educated as well. It's a very complex role to have Andrea's role, and the trust. I think that's been the missing ingredient in the system for a while now, where when we're working at odds with each other, we don't get it. We can't get it right. We seem to always be pulling the wagon in opposite directions, and nobody's winning, everybody's losing. And I think these type of discussions are what bring it together. So with that, I just want to give you each one last shot to make a final comment, and then we'll close. Andrea, we'll start with you.
Just to go off of what you just said, I feel like our conversation needs to be like, we're on the same team. We are aligned in what we're trying to do for, our members and your patients. And I think we can make it better for all parties if we partner and we work together to add value to the community and the members and patients, whatnot. So I think we have a lot of opportunity here to continue partnering.
That's great. And Dr. Perotti?
Yeah, I think I would agree with that wholeheartedly, that we have the opportunity to work together because we actually have the right points of view and incentives. We're both in it for the long haul when it comes to our people, whether it's the named employee or whether it is a patient. And more importantly, I think now we're both looking at this from the standpoint of a person and person-centered care and family-centered care that is holistic in nature, that has parity when it comes to what modality we provide the care, as well as the multicultural nature of what we need to provide. So that whole lens of providing ethical and excellent access with the service, we have those incentives aligned. And so I think it's incumbent upon us to work together to transform this healthcare system.
And, I'll just, final thought here, as you were saying, oftentimes in the healthcare system, the people paying the bill and the people providing the care feel like they're working at against each other. And I think what we're hearing here is there is common ground. And it really does require collaboration, education, and alignment in terms of how we move forward. And it will require us to pay for value, but that payment can in fact lead to much better return. And the one thing that we didn't speak to is also equity, right? Not leaving people behind, and not leaving people behind requires engaging at a much more personalized level along the lines of what we've talked about previously. So with that, I'm going to close it here. What a great conversation, Andrea, Dr. Brody, and look forward to working with both of you as we move forward.
Thank you.